This video will cover the use of robotics in stereoelectroencephalography. We prefer to use bone fiducials for stereotactic registration. Here you see the infiltration of local anesthetic into the anticipated bone fiducial sites. A stab incision is made at each of the bone fiducial sites. A power drill is used to insert each of the bone fiducials, taking extra care to stabilize the base to prevent rocking and ensure good bony purchase. We then use an intraoperative three-dimensional imaging system to obtain registration images. It is important to obtain the skull base inferiorly and all of the bone fiducials superiorly in the registration image. The patient is then placed into a head frame. It is important to note that the base of the head frame should come below the level of the zygoma, especially for amygdala and hippocampal trajectories. This will be important to ensure the robot arm does not contact the frame. The robot is then brought in and secured to the head frame. Optimal head position will be dictated by the trajectories planned for the case. However, in general, the neck should be in a fairly neutral position and flexed. The robot arm is then registered to the patient in stereotactic space by touching each of the bone fiducials sequentially. Registration is verified using anatomic landmarks and verification of the bone fiducial's location. The planning MRI is then co-registered to the intraoperative registration image. The intended trajectories are shown here. As you can see, based on this planning document, we planned 12 trajectories for this patient. The robotic arm is navigated to the next intended trajectory. The purpose of the robotic arm in this case is to act as a working channel, which will be locked in a stereotactic trajectory. We should note that in order to maximize optimal viewing angles, the steps that you're about to see may be of different trajectories. The skin is marked at the intended entry site. A stab incision is made. The drill is introduced through the working channel and feathered through the soft tissues to contact bone. The craniostomy is then drilled on full speed. Dura can either be opened by intentionally passing the depth of the bone with the drill, or by removing the drill and using a stylet with monopolar electrocautery. It is important to remain coaxial with the drill to not put undue pressure on the robotic arm, which can cause skiving. The anchor bolt is then passed through the robotic arm's working channel. The anchor bolt is then tightened to secure it to the skull. It is important to not over-tighten, as this can cause stripping and pull-out, especially in the amygdala and hippocampal trajectories where the bone is quite thin. Once in place, the stereotactic trajectory is encoded in the anchor bolt. The white anchor bolt cap is then applied, and the robot arm is driven forward to just touch the tip of the white cap, which is then used to measure distance to target. That distance to target is then scribed onto the planning spreadsheet, which is used to calculate the depth of the electrode. The calculated electrode depth is measured with a slide rule on both the stylet and the lead and marked. For this purpose, we use a marking pen on the stylet and a steri strip as a stopper on the lead. The stylet is then passed through the anchor bolt to the intended and marked depth. The stylet is removed. The lead is then inserted into the anchor bolt to the depth marked by the steri strip. Once at the intended depth, the white anchor bolt cap is tightened, which is a pressure fit cap that will secure the lead in place. Each of the exit sites is wrapped with iodoform gauze to preserve sterility as best possible. The head frame is removed from the patient, taking extra care not to displace any of the leads. Once extubated, the patient is recovered in the post-anesthesia care unit and subsequently transferred to the epilepsy monitoring unit.